Well, hello and welcome to the Metropolitan Fire Chief Association's Leadership Development Podcast series. This podcast is for Metro Chiefs by Metro Chiefs, engaging in conversations about issues that are relevant to members of our association. This series, however, can be useful for current or aspiring fire chief officers in any size department in the U.S. or internationally. Today's topic is yet another important one to the Metropolitan Fire Chiefs around the globe, but more importantly to the communities that we all serve. It's a frequently discussed topic that challenges and impacts fire departments and communities from coast to coast. And that topic is emergency medical services, specifically innovation in that space. With us for a conversation on this topic are two amazing fire service chiefs. I'm a little bit biased, I must say, and amazing humans as well. Deputy Fire Chief Jayme McConnellogue and Fire Chief Randy Royal both come to us from the Colorado Springs Fire Department. Jayme's a 26-year veteran of the Colorado Springs Fire Department and is currently serving as the Deputy Chief of Emergency Medical Services. And prior to her appointment to Deputy Chief, Jayme served 5 years as Battalion Chief of the Medical Division and Community and Public Health Division, where she was responsible for the EMS system and was committed to developing, improving, and leading the delivery of medical care in the community and in the region. In the Community and Public Health Division, Jayme set the vision to help people receive the right care professionally and compassionately at the right time, with the right resource, for the right cost through multiple innovative programs. And I can't wait to hear more about that because that's exactly why we're here. Jayme, you've risen through the ranks beginning your career in 1998 as a firefighter and then promoting to paramedic, lieutenant captain, BC, and now currently serving as the deputy chief. And you've been appointed to the statewide Responder Strong Advisory Board and the advisory board for the Colorado Professional Firefighters. You've been a committee member for the Colorado Fire Chiefs Health, Safety, and Survivability Committee as well. Within CSFD, you've passionately served as a member of the executive coordinator of the CSFD peer support team since 2006. And you've continually sought ways to be involved in ensuring and enhancing the safety and wellness, not only for first responders and the firefighting community, but also for the citizens of Colorado Springs. You received your National Register paramedic certification in 2002, and you keep that in Colorado, so that's fantastic. You've got a Bachelor's of Science in business accounting from the University of Phoenix. So thank you, Jayme, for being with us today. Chief Royal, otherwise known as the IAFC's 2024, you knew I was going to pull that out, right? IAFC's 2024 Fire Chief of the Year. You're kind of a big deal, and I know that and appreciate you being with us. You've been a member of the Springs Fire Department since 1987, and you've worked in EMS or emergency services in general for over 46 years now, with 28 of those as a paramedic. You served as a chief officer for 19 years as a battalion chief, shift commander, deputy chief, graduated from Flagler College, and regularly attended the National Fire Academy, receiving the EFO designation, one of my favorite programs. Also earned CPSE's designation as a CFO, presented numerous classes, including a great panel with me. So thank you for being there with me at the Keystone Conference. And others include the Colorado State Chiefs Conference, Fire Rescue International, and the Missouri Valley Chiefs Conference. During Randy's career, he's been involved in many programs and projects to include initiation of the Tactical Emergency Medical Program, worked in early hazmat and tox medic programs, managed the medical division, helped develop awards and recognition programs, chaired the department's rebranding committee, and presently leads the pandemic task force. I probably don't do that anymore, do you?
No. And that transition.
Thank God.
That transition to Jayme. She got to take that over.
Oh, did you? Jayme, I need to add this to your resume here.
Yep.
Let me see where I was. Been recognized over your career with numerous awards to include 2 medals of distinguished service and the Firefighter of the Year award. But Randy, you say in your bio you're proudest for being recognized as part of the department's efforts with the Castle West Department Fire, the Waldo Canyon Fire, which I've heard a lot about since moving out here, and the Black Forest Fire. So I can't think of 2 better people to be here with us to talk about this. A lot of background in innovative projects around the medical service delivery space. And I tried to hit on those bios, I pulled from the website, and they hit on a lot of highlights of your career. But if you've got any areas that are really important to you that we may have missed in covering that, please do share those with us if you have any.
The one thing I'll throw out is we also are both members of FESD. Yeah,
gotcha. Okay,
I got to throw that out for Mary Beth especially. But
so, which is the best cohort?
Cohort 12.
Our class, yeah,
the one that's going on right now.
Our class is Mary Beth's favorite. So I had to throw.
Oh, is that what it is? Okay, well, you'll get the endorsement. We'll see whether or not she gives us a thumbs up or not. So if I can kick it off, and Jayme, I'll really pitch this one to you. This first question to you, just to set the stage for us a little bit. How have you seen the role of fire departments in EMS evolve over time, and how has it incorporated EMS as a core function of what we do on a day-to-day basis?
Well, I would say that EMS has changed in a way of just the access, through 911 relative to medical calls, and EMS has grown exponentially. It was pretty significant even when I came on in 1998, but I'm thinking way back to when 911 first went into play in the late 60s, early 70s, and we couldn't even get people to use it, to call, for it. And now people have learned to use it too well. And so we're left to adapt to that and find different ways to respond. And I'm going to use that word respond loosely, because I don't think in the future, and definitely for us, it doesn't necessarily mean a physical response. And I think we'll get to talk about some of those things as we move forward. But we're just left to figure out the needs of the community and the best ways to serve them. And for us, for our department, that's 80% of what we do. And so of that 80% of EMS medical calls, over 40% are very low acuity in nature and didn't really require the 911 call, so to speak. So I think it's adapted and changed a lot, and it will continue to. And if we're not moving and progressing with the change, then we're not going to be positioned very well to respond to what are our true emergencies, where we really need to be, available.
That's awesome. And so you said about 40% of them you're finding hyper low acuity or no response needed at all.
Yeah.
And that's pretty impressive. And I think that's probably pretty well aligned with what the nation's seeing in the industry. Randy, I think your bio said 46 years in the industry in emergency services. You've watched a lot change over the years. How have you seen it evolve? And are you able to articulate some of the unique challenges that we face as fire service or fire-based EMS systems, and how some of these innovations that you see coming are impacting that service delivery?
Yeah, I can tag on to what Jayme shared there as well. But we always talk about, she mentioned this, going back to the 60s, 70s when the system first started, the 911 system, and we both share the story of, and this is going to be true across the nation with others. But if you were working during the early years, you would get elderly people apologizing to you for calling 911, even with a bone sticking out of their leg, right? They would say, "We know that this is for critical emergencies. We're so sorry to bother you." We're going, "No, you called for the right reason." Well, the transition went from those critical calls to a lot of people's first access into medical care. So whether it is that they don't have any insurance or medical provider for themselves, or they don't have transportation to the hospital, whatever, 911 became the easy access for those type of calls. And that's why every department out there in our nation has seen an increase in medical responses, is because we are the ones that are going to come take care of their need and help them, right? So we started looking at this over the years and going and actually I'll share just briefly a story when I was running the medical division, and some of the addresses kept popping up, and I'm going I'm curious. And so with staff, we looked at 7 total. And I was curious, how many times did we run on those 7 people in 1 year? And I'll throw that out to the public. And they typically say something between 20, maybe 50 calls in a year for those 7 people. The actual number was 1,000 calls on those 7 people. So obviously, we would call these our frequent flyers or, super utilizers, those type of things. And we joke that we call them our most loyal customers now. So what we did is we took a look at those 7 people. One of them had a legit medical problem where he had a hip that he would just roll over in bed. It would pop out, right? So once we figured out that was his issue, we helped him actually get access to the surgery that he needed, and he never called again. 2 of them were elderly, living in conditions where they didn't have the resources to take care of themselves. We helped them get the resources that they needed to live by themselves, and they stopped calling. And then the other 4, and this is going to be true across the nation as well, the other 4 were mental health. So we started looking at how can we address these better, and that was really the beginning and the impetus of our community division of community and public health as it exists today. Started with a team that focused on what we call super utilizers, 911 abusers, however you want to do it, frequent flyers. But it focused on them. And now it still exists today. But what it does is identifies people that are in that boat, and a unit goes out to figure out why they're calling and how we can successfully get them the resources they need so they don't have to utilize the 911 phone call. And again, out of that grew a lot of other programs that we can talk about.
Yeah, it's interesting because I think what you're describing is, these are some conversations that I've had in the past with different departments, is the community's telling you what they need, right? And we can, and not because they're clearly articulating it. Like I have, barriers to healthcare, I have barriers to transportation, I have barriers to treatment or medication, but they're telling you through the 911 calls that you're getting. And when you send these teams out here, right, the traditional services that we've been providing historically, right, since the 70s, are not addressing the problem. The you call, we haul worked for chest pain, and the person you described with the bone sticking out of their arm, that served the community member well. But those same systems, that same infrastructure isn't meeting the needs that the community is articulating through their 911 calls now, right? So you have innovation in traditional EMS, which, Randy, I'll kick this to you again, then I'll follow up, Jayme, with you. 10 years ago or 20 years ago, what did innovation in EMS look like? And now in 2025, what does innovation in EMS look like today? And Randy, so I'll ask you that question. Jayme, if it's okay, I'll follow up with you right after that.
Yeah, and I think going back to this problem, innovation back then was getting critical care to our patients, the ability to provide medications, the ability to provide more diagnostics, IVs, defibrillation, surgical procedures. All that was very innovative and was directed at critical emergency patients. Unfortunately, as years went along, as I was talking about, that 911 system morphed to where it became people's direct access into to the system, and that's where we need to address it. Now, all those critical procedures and abilities are still there, and we're still improving on the care that we can provide. And there's some exciting things coming down that we've implemented that are impacting our patients. One program, the whole blood program, which started in May, is having a tremendous impact on our community. Those things are still there. So we still want to strive and be innovative on the actual presentation of care on the emergency level. At the same time, we're looking at those low acuity calls, those mental health calls, and trying to better address them and pull them away from our most needed critical resources that have our paramedics on them that deliver that critical care, so that they are more available to provide that critical care.
And Jayme, now you're in charge of innovation in this decade, or even really, I mean, it's moving so quickly now, right? The things that you're changing there to accomplish what Randy's talking about. So Randy's saying innovation around critical care, right? We look at Johnny and Roy in the big tackle boxes, right? And defibrillation and more independent function, even to the level of ultrasound, all around acute care. But a lot of the innovations, Jayme, that you're working on are not acute care processes. They're different and responsive to the new demands that are hitting the system.
Yes, absolutely. So what Randy's describing is the one-size-fits-all department that we were 10 years ago, right, relative to response. And so while we're still doing all the things that, we were innovating on, previously 10 years ago, we're doing that, and we're innovating on response. And when we innovate on response, then the benefit to that is what the citizen actually gets. So they're actually getting the right care too, which is not the acute care package, which is not the firefighters that are trained in multiple different ways, to do multiple different things relative to rescue and firefighting and emergency medical care and all of that. A lot of our innovative programs now, we staff civilian paramedics and EMTs, and they're focused and they specialize in the specific care, that we're providing to the citizens. So even relative to, we, have 6 different programs in our community and public health division, 1 additional tiered response program out of our medical division, and those are all staffed by civilians. And it is amazing, and it is the future. And what I really like about it is what I just mentioned. It really gives them the opportunity to hone their skill set specifically in one area of focus, which I think is fantastic.
Well, you really piqued my interest there, because so we're going to go a little bit off. I know there are some questions that I've got written down, but you specifically talked about 6 different programs now that exist. And these are innovations within the last, how many years?
Let's see, since 2012.
Okay.
So 12 years.
Okay. So in the last 12 years, you've developed 6 new programs that address specific needs in their communities. Can you break those down for me and tell us a little bit about what those programs are, and maybe even a little bit of the why that was the catalyst?
Yeah. So actually, Randy has already talked about the why. So when he was giving the example of, our most loyal customers that kept calling, and us trying to learn what their true needs were, that's what started our super utilizer program, which was CARES. That was the only thing that we did outside of our normal traditional fire service response, was the CARES program that we implemented. And that was really looking at the examples that he described, specifically going to the homes of those people, knocking on the door with our medical director and a sworn individual from the fire department, and learning about why they were calling, learning about what their needs were. And we just kept growing and enhancing that based off what we learned. And, really the reason why it works for us, and it's because it's our superpower for anybody in the fire service, and that is people will open their doors to us. People will open their doors to us when we show up as firefighters. They trust us already. Like we already have that in, and that really benefited us when we were trying to understand how to serve that population, reduce the calls for service that were coming in through 911, and more effectively providing the citizen with what their true needs were. So that's how that started with CARES. And then we created a division, our Community and Public Health Division. The next program we established was also one of the examples he provided about mental health needs in our community. So that's where we started our community response team. And that team has a fire paramedic, it has a social worker, and it has a police officer. And so with those 3 individuals on one unit, we're able to address all the needs around high acuity behavioral health, which is a lot of calls. So it impacts not only the fire department, but the police department as well, that are tied to these types of calls. And I want to make it clear to everybody that the law enforcement officers that are on these units are not for law enforcement. They're there to ensure that the scene is safe, that we're able to do what we need to do to navigate those individuals directly to the care that they need. It took years for us in our community to be able to establish those relationships and to be able to direct admit those individuals into psychiatric care facilities and to completely bypass the emergency departments. So it's had a huge impact on the fire department, the police department, and our emergency departments as well. So what we learned from that program, and we just recently in this last year, was we stood up our alternate response team. So that team is one that addresses the low acuity behavioral health needs in our community. And so that's staffed with a crisis navigator and a fire EMT, not sworn, but civilian, like I had mentioned before. All of our folks that work in community public health division are civilian. And we're still learning in that. That's one of our newest programs that we have out of community and public health. And we're still learning. Like, we're really big in community and public health on piloting programs and learning. We have the majority of our people and our program are funded by grants. And that's really great in some ways because it gives us those opportunities to learn, with dollars from, other sources outside of the fire department about what the needs are. It's not so great when a lot of our staff are tied to those grant dollars, right? Because they don't have that same job security that other people do that work in the fire department, for career. So we've been working really hard, and we're actually just over the hump of 50% of that division being funded by our general fund and the remainder by grant funding. We'll always have a desire for grant funding in community public health just based off what I shared. It allows us to really innovate, and learn. So let's see. I mentioned CARES, superutilizers, CRT, ART. Another one is our transitional assistance program. So TAP. Everything has an acronym, right, when you're talking about medicine. Mm-hmm. So transition assistance program is a program that stood up. It works with our judicial system. It is to try to stop the cycle that happens of people going in to jail and coming back out and falling into homelessness again, and then moving right back in through the judicial system. And so we partner with our municipal court and have a really wonderful relationship there. And our judge for municipal court, he just can't say enough great things about the work that those teams do. So we have a behavioral health professional directly embedded in the jail. And so they have that opportunity to build those relationships right there. And then we help transition them when they come out into all the appropriate resources and care that they need. So we try to stop that cycle.
How do you answer the question from perhaps some, because you've all heard the adage, right? 100 years of tradition unimpeded by progress, from some of the traditionalists that say, is this the right space for the fire service to be involved in? Because I know you both probably hear that from internal and maybe even external stakeholders. Absolutely. How do you respond to those questions, whether they're coming from the community or one of your key stakeholders?
Yeah, I think that's a great question. And it's a question we ask ourselves with every new thing that we start, right? Are we in our lane? So you have to understand what your lane is, right? To be able to ask yourselves that question. And really all of our programs work. A couple of them are directly operating in the 911 system. The other ones that are not, it's to alleviate the calls from ever hitting 911. It is being incredibly upstream from what's eventually going to get downstream, right, and hit the 911 system. So yeah, we do field those questions. I would say that internally with our department, I haven't heard that in years. I heard it a lot when all this was first starting because it was all brand new. We were breaking tradition and, we were doing things differently, and change is hard, even when change is good. And so we don't hear it internally anymore. And I think we pretty rarely even hear it externally. And that's through demonstrated success, from what we've been able to do with these programs. So
did you guys experience, Randy, this is a question for you, experience the whole sandbox thing, like stay out of my lane? You've got lots of partnerships with probably some community health program, right? Crossover into social services or crossover into what some of the home health agencies maybe are providing. You're swerving over into PD and having to partner with them. Have you had any barriers to that, or perhaps some stakeholders that you had to work a little harder to get them to really buy into your vision, your collective vision, with what you wanted to do and how you wanted to impact this upstream problem?
Yeah, I think a lot of that came to the early work through the medical division, and even before the community and health division was in place and named that. But that initial work, Jayme mentioned our superpower of being able to go up to people's doors and go talk to them. Well, I think the other superpower that we have is being collaborative. And so everybody in our community was siloed up. I mean, and at the time, even there was kind of an aside issue with our detox center, whether it existed or didn't exist and who was going to fund it and all that kind of stuff. So it was really through the medical division of going out and getting all the players together and talking through this and being able to share our vision for it and the why behind it, which is the why was to more properly manage the 911 system, and which was impacting our whole medical system, right? So it was getting buy-in, and now, I mean, I can tell you, we have such great support through all of our community partners, inpatient, outpatient, behavioral health, the police department, the social services, the homeless services. All of those are in like that Jayme shared. You know, our lead judge in the community, he's one of our biggest advocates because he has seen the impact on his court system. And it's really tying these all together. And I think one of the questions you'd ask was about how this all, the support for how this all ties together. And as people have seen the success of it and seeing that the crossover that has happened involves all these other agencies, but us being kind of the center of it because of people calling 911, has been just very beneficial, and not only to the patients, but to the services as well. One example of that is going back to the CRT, so the mental health units. Again, this is going to be true for fire departments across the country and police departments. Prior to our programs going in place, almost 100% of the time, we would take those mental health patients, load them in an ambulance, send them to the hospital, right? The hospitals weren't prepared to deal with them. They don't deal with mental health. And so they would either sit on them for a couple of weeks and not giving them any, the right care, or more likely than not, they would kick them out in an hour or less. And guess what would happen? We would run on them again, pick up that same patient, load them in another ambulance, send them back to that same hospital. And it was just way inefficient. Now, through that program, and this is where the hospitals love it and are very supportive of it, and our behavioral health people are, agencies within our community are very supportive of it as well, because now we're taking those same patients, and 60% of the time we're able to de-escalate them on scene and leave them with family and friends. 25% of the time, through not an ambulance and through not a response from our heavy apparatus, our PD, that unit is able to take the patient either the inpatient or outpatient mental health treatment, and get them the right care. And then 15% we still transport because they have medical issues. That's a huge change in one way helpful to the hospital systems, frees them up and lowers the patient count in their ERs. Way helpful to our behavioral health partners, because now the patients that we're seeing are getting brought to the right care, whether it's inpatient or outpatient. And then tied to what Jayme shared is we're able to track through all of our different programs these same patients, so that we can track where they are in the system. And if they do end up in the judicial system or in the jail system, we still know where they're at. And we can try to ensure that whether it's behavioral health or substance abuse care, that they're continuing to get the right care, so they don't drop off the system and then go back into having the problems.
And we face some challenges, right, as a nation. I mean, I know this is a little bit off of the fire department based programming, but are you still seeing the highest acuity of those patients, the ones that perhaps need some more intensive care, still spilling back into the system? I'd seen some statistics that talked about Colorado specifically was like 49th out of 50 as far as behavioral health care infrastructure.
Right.
But are you still seeing, even with all of these programs, some of those recycled back into the community and
Yes.
still falling through that safety net?
Yeah, absolutely. And the problem, I'm a big preacher of this, because you're right. Colorado has always been in like 48th, 49th in all the states for mental health funding. And the impact of that is, and we see it today, and this goes to your question, we have short-term care for people. What we're missing is long-term care. And whether it's our mental health population in general, or specifically our homeless population, the resources aren't there to get them the long-term care. And that's a battle, because most of them aren't going to get cured under a short-term system. And so we have success, and we have had seen a lot of success on the homeless side and the mental health side by getting them into resources, even if they're short-term care. But there's a group of the population that they're only going to get better with long-term care, so they do pop up again.
So perhaps we can discuss the long-term advocacy, right, at a higher level, because there's only so much we can do, right?
Right.
Fire department, I think we've really expanded the services we provide. Jayme, I'm going to put you on the spot a little bit here, right? Because we talk about, you mentioned piloting, and you mentioned some of these great programs around behavioral health, around meeting some of those unmet needs to keep people from having to call 911 in the first place. Any failures you could think of, right? So you run a pilot program and you say, I think, all the data that I've seen is pointing us in the direction that this is going to be the solution. Are there programs that you've started and you didn't see the benefit? And if so, what were they? And maybe why do you think that they didn't take off the way you wanted them to?
Yeah, well, okay. I'll talk about the one that we piloted 2 different times and failed at it both times. But now we have what I think is our most successful program that's born from those 2 failures, which is our community medical response. So those are 5 units that we have on the streets every day, responding to the low acuity medical calls directly off the 911 system. So, the Alphas, Bravos, those, like they never hit, our heavy apparatus. But the 2 times we piloted and tried over 2 years, we really failed because we had so many. We didn't really know how to do it effectively, right? And it had to be collaboratively for us with our police department, who runs our dispatch center. So there's a lot tied to it. You can't just, make the decision that you want to respond to these calls. Like there's so much that goes into play with that. And we really focused solely on alpha calls when we first started. And because we weren't able to dispatch separately and do some of those things, it just failed 2 times in a row. But part of what we were able to really glean from that is just a really great understanding of low acuity calls. So during those pilots and trials, we spent a lot of time with our medical directors digging into all of the determinants, trying to determine what was most appropriate for these types of responses. So medical directors are going to have their medical opinion. So from a medical standpoint, you don't need to be there, in 8 minutes. You're okay to not be there for an hour. If somebody's cold, dead, and stiff, they're going to stay that way. There's nothing that you can do for that, right? And so it was working through all of those different determinants and landing not only medically, but operationally too, because cold, dead, and stiff and waiting an hour for the fire department to respond doesn't work either, right? Because what a family member walks in and finds their loved one like that, that's not. So you can see, we went through these huge processes to land where we're at today. And I would say, Randy, you could disagree with me if you like, but I think that is what is making the greatest impact on not only our community, but our fire department. Mm-hmm. Our call volume was growing at such a pace, we were not able to keep up with it. And the burnout rate of our firefighters, and even quite honestly, firefighters leaving our department because they didn't want to run 26 calls in 24 hours. It was really bad. And so just with the implementation of this program, it's funny, how firefighters will be, right? Like, we can't do it. And then all of a sudden we implement this and they're like, wow, we're just like, we're slow.
Yeah.
They're funny people, but it has been a huge success. And even the feedback that we get from the community, of not, thank you that you didn't send a fire engine and an ambulance, right? Because you probably hear that a lot, even in your own department, chief, about why are you sending, both of these? We don't need this. And so we're addressing that too. We were a little concerned because it was going to be a very different way than the community was used to us responding. So in working with, our police department, when the call takers are processing these calls, then they're telling them at the end that we'll be sending a resource to you as soon as a resource is available, to just kind of help to alleviate some of that expectation of that immediate response. And it's just worked so well.
Yeah, and I would add on to that the for both the PD and the FD and also our ambulance transport units, it has freed up thousands and thousands and thousands of hours of availability time. And so for the PD and for the FD, it keeps our units available for critical, complex calls where they feel they're being utilized more for what they should be being utilized, and that has brought morale up, and they also have time to train. And when Jayme was talking about 25, 26 calls in 24 hours, you don't have time for training. You don't have time to even sit down and eat a meal, and sleeping's out. So they're receiving the benefit. We do hear, well, sometimes we're slower than what we used to be. Yeah, you are, but now you have time to do the things. And when that call comes down, you're not sitting on a sprained ankle when a structure fire comes down 2 blocks away and you can't bail on it. So there's they are appreciative of it. And that's why when Jayme first started out about talking about when we first were implementing these programs, there was some like, hey, what are you guys doing? This doesn't make sense. And now they're like, we're in. This is great. So
have you been able to quantify that? That was actually where I was going when I started to interrupt you there, was that reduction, right? And so have you been able to quantify what that looks like, what the building these programs, the kind of impact that's had on perhaps your heavy unit volume or your high acuity resource commitment times, or even response times across the city as a result of some of these programs or alternative approaches to handling the calls for service?
Yeah, I'd say, and Jayme jump in even more, but we do have data that shows the impact on it. And I can tell you that if we had not instituted these programs, and with the growth of our city, and right now we're short stations that we're trying to work to get built. And so obviously that has an impact on response times, but just being able to, when those low acuity calls impact districts that are very busy, it takes them out of service. Then obviously the next engine over has to respond, which then brings the next engine over. We were seeing such an impact of units running all over town to try to get to the next call, which has really been lessened by these units. Jayme?
Yeah, I would say what it does too is it actually can even delay your need for infill stations. When your high density populations in the urban setting is just continuing to grow, and traditional fire services put another fire station in between there. But what we know is the majority of the call volume is medical in nature, and so being able to utilize these units during the busiest times of day in the busiest parts of the city, and those are our resources to deploy, has been tremendous. One thing I will address that's much harder to quantify are our other programs that are addressing what happens before the 911 call, because it's harder to quantify that never hits the system, right? So, we report our data and successes in different ways, but through number of contacts and, different things like that. But yeah, it's making a huge impact.
Yeah. And so on that one, Jayme did mention the Aging in Place program and the homeless outreach program. Those are two specific. So to what she's talking about. And so with the Aging in Place, either, going back to the super utilizers, where we run into somebody who's calling all the time, or one of our company officers says, this person she or he is not a super utilized right now, but they're not thriving in their environment. We think they're a candidate for the aging in place. The aging in place team goes out to these elderly folks, and the goal with them is to help them thrive in their environment. So if we can get them the resources and they can still live independently, that's a win. And we have a lot of successes. But if they can't, whatever resources we can bring to them, they still can't thrive, then we try to help them get into long-term care. Both of those scenarios decreases the calls to 911. The homeless outreach program is a proactive program where the team goes out and they actually go into the camps. They go where the homeless are, build relationships with them, and with that population to get them to a level of care, or actually even a level of desire to go get care, whether it's mental health or substance abuse. It takes building relationships first. So now those teams, and they wear red, they have red shirts, which identifies them not as a police officer and not as a sworn firefighter. They're welcomed into these camps. The homeless will see them coming and they're going, hey, come on in. Where with us or with PD, more likely, they're like, we don't want to interact with it. But they go in, build these relationships, and over time, and we have great success stories with this, again, not quantifiable with response times, but with contacts, to where we have got them into programs. And we have a number of people that we've gotten off the street into long-term living through this program.
So you guys didn't do this in a vacuum, right? I think one of the beautiful things about the fire service, as evidenced by what we're doing right here, right now, is that we look to our peer localities or coast to coast, or even internationally, right, to see how people are addressing the common problems that exist within the community, or common challenges that members of our community, our customers, are facing, and how can we innovate. Can you think of any organizations that really stand out in your mind as departments that you looked at as you were building out these programs, or did you just really focus on your specific community and its uniqueness when you built out these programs?
Yeah, I would say that we were actually on the cutting edge of that. I mean, it was not the norm to do what we were doing and what we were looking at. We've actually over that time period, we're probably close to 80, if not more than that now, different departments from around the nation. And even maybe a month and a half ago, we had a group from the Ukraine that came out to look at our programs. We've had, and we've heard of successes of other departments that have come in here, taken what we've done and implemented it in their communities, and are having great success with them now. Doesn't mean we haven't learned from others on lots of other things, but I can tell you that these initial programs were homegrown.
That's super exciting. You're on the bleeding edge, so to speak, of some of this stuff. And I'm aware of departments, including ours, that have come down there and really sought guidance because of some of the innovative things. So that's super exciting to be in that position. Both of you, the creativity that you've been able to use and capture, not just from you guys, but from your members, I'm sure as well, to creatively solve that problem. Yeah, go ahead.
Yeah, I was going to throw out now, I will say we are always looking at other departments to learn from them. Mm-hmm. And a very, very good example of this, because I want to give them a shout out, is I mentioned our whole blood program that we started in May. We went out and looked at other departments, but mainly San Antonio, because they've been doing that for a while. Lots of kudos to them, and them being open to us coming down and learning from them. And it's been a game changer for our community, being able to implement that program. So even though we're proud of our successes in our innovation locally with community and public health, we are always open, and I think every department needs to be at looking at what other departments are being successful in and pursuing that so that you can make your department better.
So I'm curious, like people don't just get tasked to do this kind of work, right? They do it because they've got this drive inside their heart to make their communities better, make their service delivery better. And so, Jayme, I'll start with you on this question because I'm curious. We often talk about our job as chief officers as we're the chief storytelling officer, right? We take data that's boring and sort of clinical terminology, and we turn that into a story that demonstrates the impacts of the programs that we're running. And so I'm curious, Jayme, do you have a story that stands out in your head that the outcome was changed or impacted in a positive way because of the programs that you've had the opportunity to develop in your department?
Hmm.
I threw you a curveball, didn't I?
You sure did.
You're welcome for my service.
I'm really trying to think.
So Jayme, I am sorry. I apologize to all the people listening out there because I should know it, but we did have a person. And Jayme, you remember her name, but she was one of our patients. I think had an alcohol abuse background and was in a real mess. I think even homeless, that ended up working for us. She doesn't work for us anymore because she's moved on, but
she's moved on in a great way. Yeah, that's Melissa. And she became part of our community public health division and worked for us. And now she's actually doing this same type of work in our community at a much higher level. They're COS Hope, where they open their doors to, the homeless population and really cold weather events and that. And so, thanks, Randy. Yeah, that's my story.
You stole it from him. Yeah, no fair.
Yeah, but Randy's right. Like a lot of people that we get to impact in our community then become very motivated, to want to impact others as well. Oh,
it's great that it had that much of an impact on her life that she wanted to be part of that for other people. That says a lot. And I'm sure you all are being super humble, and I'm sure there are all kinds of if I asked your staff, I'm sure they would lay it all out there for us as far as how it's impacted about thousands of people in your community. Let's start to look a little bit ahead to the future, and we've got about 10 minutes or so left in the podcast, but I want to start looking ahead, right? So we've looked at the past, what innovation was, years and years ago, and what it has been in your case since 2012. To address the contemporary issues, let's start looking ahead and what you see as challenges that we're going to face in the future, technology that we might be able to use in the future to better vet calls as they come into the system and better allocate resources. What do you, if you're looking in your crystal ball of community medical services or community whatever kind of services, what are you seeing as the challenges, and what are you seeing as some of the solutions and technologies that'll help us meet those?
I'll talk about one because I think the next great step to outcomes has to involve the community, has to involve the citizens. And so Pulse Point, I don't know how familiar everybody is with that, but that opportunity for citizens and others to be made aware of when there's a cardiac arrest and to be able to start CPR immediately and to apply an AED. And we're actually doing some of that work right now, in our community and regionally to identify where we have AEDs across, our city so that we can then use technology to make these notifications and utilize those not only civilian resources to assist, but also like the actual equipment, the AEDs and that. I have a strong goal and desire before I leave this department to have an AED in every police officer's car because they are mobile and they are everywhere in our community. And that is truly the way that you save lives with those specific type of medical situations. Those folks that have CPR started immediately are the ones that have the greatest successes and outcomes. It's just knowing it's happening and then having, somebody be able to do that. So that's one thing along with everything else we've been talking about. But Randy, do you have something?
Yeah, I was going to just add on to continuous things like nurse navigation through dispatch and being able to, the calls that we're talking about and the patients that are going into the different programs that we have, whether it's CMed with low acuity or the mental health, or some of this is going on already. But just to expand upon that with the ability to have a screener within dispatch that can even take some of the calls off of those units based on being able to resource them to a doctor's office or a clinic and get them the transportation there as well.
So a little more human intervention in the upfront. That's not driven by that. How do you think artificial intelligence plays into that? Just out of curiosity, there's some news coming out of the EU, right, where they've banned the use of artificial intelligence in certain settings. And are you using that now in any of your environments, or how do you see that? Does that make you nervous, or does that make you excited as we move forward, is seeing those things integrated into dispatch centers or call processing or language lines or whatever? What are your feelings on that?
Yeah, anything, Jayme?
Probably not anything different than what you would say.
Yeah, I was going to say, so your answer, whether it's scary or whether it's good, is yes. It's both of those. We have some big concerns and actually just today our PIO was looking at a virtual thread of of the fires out in California on a specific home, and in that piece, all of a sudden she goes, "Is that a body?" And she backs out, and it's a skeleton, burned skeleton in that house. Look closer, and it was AI. Somebody had thrown that in there while all this is going on, and throws a skeleton in the middle of this home that did not exist. And so that's the scary part of it, is this, what can go there. But I do believe that there's going to be value in helping us screen and get resources to the right people using AI technology. And it's a lot of it's to be determined, right? Because I think we're just on the cutting edge of that, but we're going to have to be very careful with it as well, because it can be misused and manipulated in a wrong way. The other thing I will throw out there, and I know that there is a department out there that's doing this, but we're looking at also, Jayme was talking about the AED. We've got a very active drone program, and it's going great. But one of our visions on that is to be able to use the drones to deploy for things, at least to start with. Maybe it'll be more down the road, but an AED, a tourniquet, Narcan, an EpiPen by drone to patients that we know we can't get our apparatus to quick enough to do it by drone, and dispatch will take them through. Here's how you use it, and be able to virtually see them using it at the same time. That's going to be a game changer as well.
That sounds really cool. I'm sure with all the Air Force bases and Space Force bases around the state, that creates some more challenges for any kind of unmanned vehicles that we're flying around.
It's interesting, but it's actually it's working, and both with us and our police department. Our police department has what's called the Real-Time Crime Center, and they're using their drones. And this is another place where we have a really great collaborative relationship with our police department. And this Real-Time Crime Center is also, I foresee in the future, we're going to have, whether it's a sworn or civilian, but we're going to have a full-time person from our staff in there to manage the fire rescue side of it. We were in there just the other day, and we were looking at it, and a call came in, and I challenged the police chief, because I said, you set this up, didn't you? He laughed. He didn't. But a call came in for a guy setting bushes on fire at a certain intersection, right? They put the drone over there, and initially the guy wasn't right at the intersection, but he was within a block, and they found him by an abandoned building. They zoomed on him. We actually were sitting in this room watching him light a bush on fire with the drone. And they arrested him, and they had a picture of him doing it. And that's a pretty, open and check case. But I think that's one of those things on technology side that we're just starting to to see the benefits of. It has been a game changer for us on the fire and rescue side, on high angle rescues and trail evacs and traffic accidents. The technology is a game changer. So.
Jayme, if you had to give some advice to a department that perhaps has been lagging, maybe a little bit behind, or has some of these challenges, but doesn't know where to start, there's no such thing as low hanging fruit, right? In with all the complexity that we're dealing with, but where is it that you would really start this process of innovating in your fire-based EMS system if you had it to do all over again, or if you had to give that coaching and mentoring to a deputy chief of EMS in another department somewhere in the U.S.? What advice would you give them?
Well, what I'd love to say is come see us, because we love talking about what we're doing, and something that we really recognize is it's unique to our community. And so we love to not only share what we've done, but we love to also help other departments learn what's best for their community. So to understand what's low-hanging fruit would require an analysis of what's their heaviest call volume related to, and what are their greatest struggles with, to try to figure that out. But we're just at such a great place where a lot of this is starting to change, across our nation, that there's a lot of opportunities that you don't have to stop and start and have successes and failures, to just try something right away. When Randy was just talking about the drone program with the police department, what I love about that is that's their version of tiered response. They're using those drones and they're launching them from the police operations center. They're going to be launching them from our fire department headquarters as well. And they're able to use that to determine whether or not a patrol officer even needs to go. And so I just love the innovation, that's happening across the board relative to public safety and emergency response.
That's great. I would love to see that here, especially considering the traffic that we have to deal with to get there. Randy, from the fire chief perspective, what advice would you give to leaders in our service that are really trying to embrace innovation, maybe even being trailblazers, as you all have talked about here? You're not following. You're following few others lead, right? You're really kind of cutting that path to these innovative programs. So what advice would you give that fire chief? What advice would you give me sitting here trying to convince city management or council to give me the latitude to take some of those risks or try and blaze some of those trails?
Yeah, I would say a couple of things. One is look at what your issues are and be willing to look outside of the box. We talked about the tradition, right? We need to really be focused on what's the right service for our citizens, and how do we provide it at the highest level possible. To do that, you do have to look out. It's easier to sit in and do the normal day to day. This is what we do, and this is how we've always done it. But in the long term, that's going to potentially degrade your service to your community. So how do we step back? What are our issues? What's impacting our bottom line mission? And how can we adjust to make it better? And part of that is there's people in everybody's department that are chomping at the bit to get more involved in their departments and that have great ideas. And when I say that, I'm the gray-haired guy that's been here for a long time, right? There's guys that are way better at technology and AI and those type of things that are coming up in our systems. We've got to allow them to be participants in our future, and to think about, to not shut them down when they come up with a new idea and say, hey, have you ever thought about this? And sometimes those won't work out, whether it's financial or just logistic wise or whatever. But the ones that do work out, and I'll say, going back to what we started with our community public health division, that was stepping out of the box. That was doing something that was totally different and allowing folks to be engaged. And I can tell you that we've had, I could share lots of examples of us letting our lower ranks, sometimes not our key players, jump in there and take an initiative and put the energy into it. And that's what's made it successful. The other side, or the other point I would say here is, again, get away from some of the traditional things and step back and look, how do we do this differently? So Jayme mentioned some of our staff especially within Division of Community and Public Health and with CMed, are not sworn people. I know that there's people that have angst about that, but I tell you what, our local and our local 5 union firefighters, they are way supportive because they have seen the benefit and they have been involved in the processes as we've gone along. So they see the success and they've been supportive of the success, even though it's not the traditional manner of going about things.
That's great. That's great advice. So thank you. Jayme, Randy, I really appreciate you being here. And I know that the membership of the Metro Chiefs and whoever else will listen to this podcast appreciate hearing from innovative and experienced leaders. And so let me express their gratitude for them. Hopefully they'll hit a like button or something like that. I don't know how all that works, but maybe they'll do that too. So thank you for sharing those ideas and perspectives. Do you all have any closing comments or advice that you'd like to share with our audience before I cut you loose to go back and do the good work that you're doing?
Jayme, you got anything?
My advice is don't be afraid to fail. Because when you let perfect get in the way of progress, that's the other thing. Like, we're all perfectionists and, we all have this desire to do our jobs the best, but we can't be afraid, to fail and to learn from those failures to ultimately seek great improvement.
Yeah. And I would say be open to being innovative. I mean, keep looking at what we're doing. There's changes inevitable in what we're doing. We have to be focused on our patients and our citizens that we're serving and always try to give them the best service possible. And because if we're looking that way, there is going to be change because our, fire's changing, medicals are changing. We've got to adapt. And the only way to adapt is to look for innovative ways to get better at our service.
I figured something like a be brave or be courageous would come out of both of you. So I'm not at all surprised to hear you say that. And that's the way you lead the way, right? So thank you both again. It was great to spend time with you today. And thank you to those who took the time to listen to this Metro Chiefs Leadership Development Podcast. It's created by Metro Chiefs for Metro Chiefs. If you enjoyed this session, please share it with others. And if you have ideas for topics that we should cover, please send us an email. And we promise we'll get after it. Until next time, please continue to live out the Metro vision of being a place to belong, inspiring success. Take care of yourselves and each other. Thanks.